Welcome to The Explainer. Today, we're diving into a critical bedside skill, how to rapidly and definitively diagnose a hydropneumothorax using thoracic ultrasound. We're going to walk through the key sonographic findings that will let you make this call with confidence, especially when every single second counts.
So here's our game plan. We'll start with why ultrasound is really the tool of choice here. Then we'll zero in on the single most important landmark, what we call the hydropoint. After that, we'll break down the specific signs you'll see above and below it. And finally, we'll get into a crucial differential diagnosis that can really make or break your interpretation. Let's get into it.
All right, let's start with the basics. Why has thoracic ultrasound, or TUS, pretty much become the go-to for this diagnosis? Why has it pushed something like a chest X-ray into a secondary role, at least in the acute setting?
Well, the advantages over a plain film are just huge, especially when you're in a time crunch. TUS has way better sensitivity, it's right there at the bedside, so you don't have to move an unstable patient, and you get to see things in real time, you see the dynamics. This isn't just about making things easier, it's about getting from suspicion to life-saving intervention so much faster.
Now, before we start looking for signs, let's be crystal clear on what we're hunting for. A hydropneumothorax is simply the presence of both air, that's the pneumo, and fluid, the hydro, stuck in the pleural space together. Our entire diagnostic process is built to find this specific combination.
The whole ultrasound diagnosis really hangs on finding one specific landmark first. You find this, and you are absolutely on the right track. So, when you put that probe on the chest, your primary mission isn't to find just air or just fluid. Your number one job is to find the hydropoint, that exact interface where the air and the fluid meet. And this is what you're looking for. It's not subtle, it's a really sharp, obvious boundary line. Below this line, you're going to see the anechoic, pure black of the fluid. And right above it, you get all the bright, hyperechoic artifacts from the air. This clear separation is your anchor for the entire diagnosis.
Okay, so we found our anchor, the hydropoint. Now, building the diagnosis is as simple as looking at what's happening on either side of that line.
Your thought process really just follows these three steps. You've already done step one. You've found the hydropoint. Now you just need to prove that there's a pneumothorax above it and a pleural effusion below it.
So, looking superior to that sharp line, your goal is to confirm what you already suspect is there: air. You're looking for the classic ultrasound signs of a pneumothorax.
And if you flip over to M mode, the diagnosis becomes undeniable. Normally, in a healthy lung, you'd see the Seashore Sign, the sandy beach and the waves above. But here, because air is separating the two pleural layers, you lose that lung sliding. Instead, you get this stratosphere or barcode sign. It's just a stack of straight, parallel, lifeless lines. It's proof that there's no lung moving there.
Okay, now let's direct our attention down, inferior to the hydropoint. We need to confirm that this black anechoic space is in fact a significant collection of fluid.
The positive spine sign is just such an elegant way to do this. Usually the air in the lung scatters the ultrasound beams, so you can't see the thoracic spine. But when a big fluid collection pushes that lung out of the way, it creates this perfect acoustic window. Suddenly, you can see the vertebral bodies clear as day, right above the diaphragm. Seeing that spine is your confirmation of a significant effusion.
All right, now for a dynamic finding. This is one of those signs that when you see it, you can be extremely confident in your diagnosis. It basically seals the deal. This is the Microbubbles sign. What you'll see are these tiny, super bright speckles rising up through the black fluid. And this isn't just random floating. It's a fast upward stream, all heading toward that air-fluid interface, and it's often in sync with the patient's breathing. This directional movement is incredibly specific for air bubbles mixing in the pleural fluid.
But, and this is a big but, this sign has a very important mimic. You absolutely have to be able to tell the difference between the Microbubbles sign and what's called the Plankton sign, or you could make a pretty significant misdiagnosis.
At its core, the difference is simple. It's air versus debris. Microbubbles are air, and they're pathognomonic for a hydropneumothorax. The Plankton sign, on the other hand, is just junk floating around. Fibrin, proteins, cells, which points you towards a complex effusion, like an empryema or a hemothorax, completely different pathologies.
This table breaks it down. Look at the movement. Microbubbles are rising fast, with a purpose. Plankton is just slow, swirling, passive. But the most critical differentiator, the absolute hallmark, is the hydropoint. The Microbubbles sign must have an air fluid level above it. The Plankton sign doesn't. That right there is the deciding factor.
So the clinical takeaway is really simple. Let the hydro point be your guide. Once you have locked in on a definite air fluid level, any of those dynamic rising speckles you see in the fluid below it, that's the microbubble sign. That confirms your hydropneumothorax.
So to wrap it all up, this systematic approach lets you make a really fast and accurate diagnosis right at the bedside. You find the air fluid level, confirm air above and fluid below, and then look for those highly specific microbubbles to really nail the diagnosis. And that brings us to the real point of all this. Making this diagnosis with ultrasound isn't just some academic exercise. It's the critical first step that demands an immediate, decisive, and potentially life-saving intervention. The diagnosis is made. What you do next is what truly matters.